Last but not least, let's review pneumonia, which, surprise, surprise, has also had some updates in guideline management plans. When we define community-acquired pneumonia, we're either defining it as severe or not severe. Severe community-acquired pneumonia, or CAP, is the presence of one of the below major or three of the minor criteria. Major are patients who are ventilated or in shock. Minor includes kidney dysfunction, confusion, hypothermia, hypotension, multilobar infiltrates, hypoxia, platelets low, or thrombocytopenia, tachypnea, and leukopenia. There's been an update. Defining hospital-acquired pneumonia has been eliminated from the recommendations because it does not predict antibiotic resistance. The new standard is to treat based on risk for certain organisms like Mrsa or Pseudomonas. The new guidelines also recommend only adding anaerobic coverage for aspiration pneumonia if they have an identified abscess or suspected empyema. Testing for pneumonia. Blood and sputum culture is not shown to improve patient outcomes with CAP. Sputum prior to treatment is only recommended in patients with severe CAP or if the patient has a history or risk for Mrsa or Pseudomonas. Additionally, if they've had recent antibiotic use within the last 90 days, you would want to get a sputum and blood culture for these patients. The urinary antigen test for Legionella does not improve outcomes. You really only need that if the patient has severe pneumonia or an exposure. Flu, and I would add COVID testing, is always appropriate. Procal is really helpful, but its sensitivity can vary. That being said, a negative procal should not be used as a reason to hold antibiotic treatment in somebody whom you suspect pneumonia. Before we can understand our management, we've got to review the drugs again. The top left-hand corner, I've got all the beta-lactams listed, from high-dose amoxicillin, which is narrowest spectrum, to Unison, which is broader coverage. I would add cefepime down there at the end too. Bottom left is our main tetracycline, or doxy. Bottom right are all of our respiratory fluoroquinolones, levaquin, gemafloxacin, and moxifloxacin. And top right are the macrolides, azithro and chlorothro. So how do you treat pneumonia? Depends on the situation. We'll just take it one case at a time. So if the patient's in the outpatient setting and they don't have major risk factors, you're going to treat them with straight amoxicillin or straight doxy, or you can use a macrolide, but only if the local resistance is low. This is where the update is. Our first line agent used to be azithromycin. Now it's third line. And you don't use it at all if the local resistance is greater than 25%, which I believe in our area it is. So what about a patient who's well enough to be in the outpatient setting, but they have risk factors? Those risk factors include alcoholism, asplenia, diabetes, cancer, heart, liver, lung, kidney disease. Well, the management plan is pretty much the same. They'll be on a beta-lactam, but you've got to upgrade it from just amoxicillin. Your new options are Augmentin, cefuroxime, or cefpodoxime. Alternatively, you could just use doxy, or you can use the azithro if the patient's in a local area with a low resistance. What about patients who need to be in the hospital? So let's look here. If they're in the hospital, but their pneumonia is not severe in category, and they do not have risk factors for Mrsa or Pseudomonas, you'll do a beta-lactam and a macrolide, or azithro. The beta-lactam are some of the broader spectrum antibiotics like rosuvastatin, Unison, cefotaxime, and ceftaroline. Alternatively, they could be on a respiratory fluoroquinolone alone, like levaquin. Now, we have a lot of patients who are admitted and geriatric with pneumonia. What do you do if a patient has a contraindication to the macrolide and the respiratory fluoroquinolone, like an older person with a QT prolongation, for example? Well, in those instances, alternatively, you can use a beta-lactam and doxy. And again, you're using some of the broader coverage beta-lactams like rosuvastatin, Unison, cefotaxime, and ceftaroline. So what if patients are at risk for Mrsa and Pseudomonas? Well, the main risks are prior isolation of those two organisms, or hospitalization and treatment with antibiotics in 90 days. If someone's at risk for Mrsa, add linezolid or vanc. If someone's at risk for Pseudomonas, add aztreonam or cefepime, ceftazidime, or meropenem. Any of those are fine. What about steroids? You should not routinely prescribe steroids in CAP. Studies show improvement with steroids are the studies that have showed improvement with steroids are very flawed. Antivirals are indicated in patients who tested positive for flu or now COVID. New guidelines recommend treating patients with flu regardless of when the time of onset versus the test is. Major takeaways: routine cultures are not beneficial in patients with non-severe CAP. The pneumonia severity index is recommended to determine the need for hospitalization. This is like the new CURB 65. The ATS or IDSA criteria is recommended to determine the need for the ICU. So these are screening clinical tools that can help you figure out where a patient needs to be placed based on their symptoms and findings. Routine treatment with macrolides as first line is no longer recommended unless the local resistance is low. Amox plus doxy is basically the new Z-Pak for run-of-the-mill CAP. When you're treating patients with antibiotics, 5 days is recommended, with evaluation at the end of the treatment period to see if they've improved. And that is all.